You are welcome to my channel. Thanks for visiting. Today is all about kissing disease. You are familiar with infectious mononucleosis or glandular fever. It's all the same, and majority will refer to it as mono. Please remember to subscribe to my channel. Without further ado, let's go straight to the point. So, someone will ask me, does it mean everyone has mono? And I don't know, is it everyone? Well, the answer is technically yes. For some reasons. Number one, those who even have mono, majority who have mono, they won't even know that they do. And they will pass through it with insignificant symptoms that will not even lead them to any physician. And the immunity will be built after. So they won't know. And those who even have mono and it's so severe enough, and they visit a physician and Epstein-Barr virus antibodies, Epstein-Barr virus specific antibodies is being detected, they may not know how they got it. They may not know. Because before they start showing symptoms, it would have been weeks after. And all age groups, those less than 1 year will be protected by the antibodies they acquire from their mothers. And those that are a little bit older than that, even when they have it, the symptoms, the signs will not be so severe that will warrant seeking medical advice. And the elderly, the older adults, they would have, at a point in their lifetime, maybe about 90% or greater than 90% of us would have come across Epstein-Barr virus or infectious mononucleosis, but since it wasn't so severe enough, we won't seek any medical help, and then we would have developed antibodies and immunity, and we'll be fine. So it is fair to say that those who are seeking medical attention because of infectious mononucleosis will remain the group that will suffer the most as per the signs and symptoms, which will be adolescents and young adults. Let's have a glance at the first note that I've put down here, and that will serve as the window to what the entire presentation will be upon. We'll have full understanding why this disease is more in adolescents and young adults than the younger children. Why is it that it is not so severe in them, younger children, and it's more severe in adolescents or young adults? You will understand it now in a bit. Is it contagious? Yes, but not as COVID-19? No. Then why am I paying attention to the organ called spleen? The reason is not far-fetched. In mono, you are not likely going to die because you have mono or infectious mononucleosis. You may die because of immune status if your immunity is severely compromised. Yes, there may be problem beyond necessary, particularly based on the complications. But even with your good immunity and you have splenomegaly and you are involved in contact spot, you can have splenic rupture. And if there's no immediate surgical intervention, that might lead to death. So that's why I'm paying attention, very, very close attention here. So we'll talk more about spleen and infectious nucleosis. Epstein-Barr virus, yes, that is the culprit in 90% of cases. But in 10% of cases, there will still be infectious mononucleosis, but Epstein-Barr virus negative. In that case, we'll be focusing on cytomegalovirus, Toxoplasmosis, HIV, hepatitis, and later on you have full picture. Antibodies, Here, yes, exactly. Antibodies will be formed. And what is the importance? Are we going to get immunity for a long time after? You understand a bit. How about the relationship between mother and the newborn when it comes to infectious mononucleosis? Any benefits to the kids? Would that be overrun with time? Or not in a bit? Is there a period of dormancy that the virus will undergo, just resting somewhere, not causing signs or symptoms? And will there be reactivation, and what could lead to reactivation? You understand a bit? Then some people will not know that they have mono. They will be given penicillin, and then they will develop rashes. The rashes is not because they are allergic to penicillin. In fact, might be an individual who has been taking penicillin before now and never reacted. Today, the individual is reacting with certain type of rashes. We'll define that fully. But it is not because of allergy. It is because today, the reaction to penicillin or the ampicillin or amoxicillin is because there is infectious mononucleosis. Okay, sit back and let's go. Now, other names here, the common one among youths is mono. Then many textbooks, infectious mononucleosis. Everyone, causing disease. Why is it like that? I will explain later. And some other people will put it as glandular fever. Choose anyone, it's the same thing. Why the name mononucleosis? You know, mono means one, okay? Mononuclear white blood cells were present in large number and they were pretty abnormal. That is why they got that name. Now, mononucleosis and spots. So I call it mono and spots. And why will I go there right away without even telling you the signs and symptoms, the prevention, the diagnosis, the treatment, and everything? Because it's pretty important. Unfortunately, the adolescent and young adults are so hyperactive. They will be the ones that will be trying so many things, jumping, hockey, football, soccer, all contact sports, even anything you can think of. But in a large spleen, if there's a large spleen, please, no. Then it means you will not be cleared to participate in that contact sport if your spleen is still enlarged. Okay? If you still have persistent fatigue, no doctor will clear you to go back to full sport events. Okay? All sports, you can go back to all sports when the spleen enlargement is no longer there, the fatigue has appreciably reduced. But remember, fatigue is an issue that will start gradually and will also dissipate gradually. So timing is the issue. So many textbooks will put it that, okay, at so time, you are going to go back to your sport, you are going to go back to this and that. But I will put it simply that these two factors will determine when you go back to either the normal sport or contact sport. That is the size of the spleen and the persistency of fatigue. And we'll still explain further. I will be following up with the spleen size or splenic size using ultrasonography. And of course, the history will establish the level of the fatigue. Let's quickly go through some signs when it comes to infectious mononucleosis. There could be rashes or hives. The temperature will be high, but not extremely high. The spleen could be enlarged. Some may likely have neck stiffness. The liver could also be enlarged, that is splenomegaly, hepatomegaly. There may be jaundice. The tonsils could be inflamed. And here it could be red, swollen with patches, and sometimes it could be necrotic. The lymph nodes could be enlarged, particularly the axillary and head and neck region. There may be pallor. Then there might be nosebleed when we are dealing with severe thrombocytopenia. The heart rate could be on the high side, that is tachycardia, and some will have photophobia. Then there may be bilateral periorbital edema. Then I have quickly noticed something here, splenic rupture. The individual will complain about sudden and severe upper abdominal pain in the left upper quadrant. There may be dizziness or heart racing, but the signs of splenic rupture will include severe abdominal tenderness, with guarding, decreased blood pressure, increased heart rate. When it is so severe, there may be loss of consciousness and death. The symptoms of mono will include, but not limited to, fatigue. That could be gradual in onset, but the fatigue could be very extreme. As a matter of fact, whether or not you go back to sport will be determined by the level of fatigue and the splenic size. Then there will be fever and sore throat. The lymph nodes will be enlarged, particularly around the axilla, the head and neck region. The liver will be enlarged. There may be rashes or hives. Now, you feel that people are telling you that you are pale. You may have breathing difficulties, particularly when complications are setting in. With or without shortness of breath. Some will develop night sweats, and some will have dizziness. There may be headache and even loss of appetite. Nausea, vomiting, and diarrhea could be found. Some will have chills and cough, while others will sneeze, and some will develop bloating or abdominal pain, and others will have body aches, while some will actually develop pneumonia. Let me quickly describe the rashes that could be developed if anyone with mono takes amoxicillin or ampicillin. The individual can produce generalized maculopapular erythematous rashes. But that is a possibility. So can we then use that to diagnose mono? Let me put it straight. Can we say, okay, we are not sure if this is infectious mononucleosis, glandular fever, or simply mono or kissing disease? So can we then give amoxicillin or ampicillin and see if these generalized maculopapular erythematous rashes will develop? If we do that, we run into trouble. So we cannot use that as a diagnostic yardstick. No, because we'll get sued. Now let's consider mother and child, and let's ask ourselves the question: if a child is less than 1 year, what is going to happen as per mononucleosis? Well, all kids less than 1 year will not have infectious mononucleosis, and with that, they would have acquired antibodies from their mothers, and that will suffice to keep them, the first 1 year of life. Let's quickly touch on epidemiology before we move on. Here, that will be basically on Epstein-Barr virus. That is a herpes virus, type 4. Epstein-Barr virus spreaders and the sufferers, when they meet, then there will be transmission. The reservoir here is human beings. 90% of cases of mono will be as a result of Epstein-Barr virus. And the diagnosis or the procedures, monospores will point to Epstein-Barr virus antibodies positive. Poor hygiene can open the door for early infection in life. That is why many kids living in a poor environment might have it early in life. But the peak of mononucleosis or infectious mononucleosis or kissing disease is between ages 14 and 25. That is why we say adolescents and young adults will pay more price. It's not that the rest won't have it, but they won't have severe symptoms compared to this very age group. Before moving on from here, we should realize that genetic factor will contribute hugely to severity or presentation of infectious mononucleosis. As a matter of fact, molecular biology is helping us a lot in medical field right now because almost 80 to 90% of medically related issues could be traced to genes. Causative agents, mainly Epstein-Barr virus, and that would be 90% of kissing disease or mono. It is also known as human herpes virus 4. The remaining 10% will be caused by either cytomegalovirus or HIV or Toxoplasmosis or hepatitis disease or human herpes type 6 and 7. Transmission. It is called kissing disease simply because it could be spread through saliva and other body fluids, including blood. Some literature will put it that we don't really know how it is being spread because many people will even be transmitting it before developing symptoms for many weeks. So they're like confused. They can't even trace the contact. Okay. Oral shedding can be as long or as late as 6 months post-infection onset. Then oral and pharynx will be the place where the virus will be hiding, and they'll be shedding from there for months and even decades. Some will say for average of 18 months, but just believe it, it can be there for a long time. Oral pharynx, okay? It could be found in breast milk, but it's not the source that is concerning to mother-baby relationship, and then you advise that do breast milk. No, there's nothing called that. The mother can breastfeed, though it is noteworthy to let you know that it is a possibility, but I don't think there's any literature telling us that the result of breast milk transmission of mono is so significant to the point that any mother will be advised against breastfeeding even if she is diagnosed with infectious mononucleosis. Could be sexually transmitted, and some will say, oh, is it a sexually transmitted infection? Absolutely yes. But the reason why it has not been coned down to STI alone is because it could be acquired through many other routes. And Some people would then stigmatize anyone with mono, as someone who has acquired it through, uh, relationships. So that is why it has not been defined like all other STIs as such, but it is a possibility. It is a possibility. Then true cough that is not well covered, particularly in those having it in the oropharynx and shedding it. People nearby could have it, from that, and even sneezing with droplets on any other item that the healthy people can touch. And utensils like sharing cups, someone with mono, with Epstein-Barr virus or the Epstein-Barr virus negative mono, cytomegalovirus, toxoplasmosis, and the rest of them, you use the same cup with them, you use the same plate, knife, spoon, fork, all food eating utensils, then you may get it. Sharing drinks. Just get a cup of water and transfer the same cup to somebody else near you, and you don't know whether the person has mono or not. You might get it from there. Cigarette sticks. You smoke half and you pass the half to your friend. Your friend may have your mono, or you take half from the other, vice versa anyway. So sharing a straw, seen that many times. It's my body, so the same straw to drink whatever, maybe your pop or your anything you use straw to drink, and then you transfer to someone else. You may be transferring your mono, particularly if you have it and you don't know. So you may inadvertently, unintentionally transmit it through all those routes. So YouTube will not allow us to be explicit on some things, but just know through relationship intimacy, you can have mononucleosis. That's why some people call it kissing disease. Now, prevention. How can we prevent mono? First thing first, there is no vaccine. Okay? And sources of infection is not pretty known. Although we've just gone through the slide where at least there's saliva, body fluid, seminal fluids, blood, and so on and so forth, but how people actually get it sometimes, people can trace it, because when they get it, they don't come down with infection quickly and be able to say, oh yeah, I remember it was 3 nights ago, or it was just last week, I had a guest around, or I visited a place. So it's confusing to trace the contact. So no vaccine, the source of infection is not known most of the times. Avoid kissing if you know that you have mono, but healthy people cannot know who has mono, because some people who have mono, they don't even know that they do. In any ways, if you have been diagnosed with mono, please help others. Don't make them sick. Don't share utensils. Food utensils, cup, straw, table knife, spoon, and the rest, no. Don't share your drinks. Grab your coffee, grab your pop, drink by yourself alone, and take care of the container the way it is expected to be. Okay? Cover your cough and sneezes, please, because through that you can pass it to those other people around you. Wash your hands frequently and as many times as possible, please do. All toys that the kids will be playing with in and around anyone with infectious mononucleosis should be properly washed. Decrease your intimacy. You understand what I meant? I don't want to appear, you understand what I'm trying to say. So decrease relationship. And if If you think it is a must, then cover it with, you understand what I'm saying? Condom, okay? Then avoid anyone you have known to have been diagnosed with mono. That is not to say you don't like them or you're not caring for them, but then you can pick it, and who knows who will come down with signs and symptoms, and who knows who will come down with complications. If you come down with complications, are you sure you're going to get out of it? You don't. If you are sick with mono, please don't spread it to others. Don't share cigarette stick, okay? And then let's note this. Restrictions won't solve the problem. Then another person will ask me a question somewhere that if that is the case, then why are you wasting your time going through this prevention and then transmission route? Well, if we all do this, we may put it under control more than when we're extremely carefree about it. Now, the diagnosis. Although I will have a separate full presentation diagnosis of mono, but for this purpose, let's quickly go over certain things. Well, everything about the diagnosis here will center around monospot test and white blood cell count, particularly the atypical lymphocytes. But before we go further, let's just write this somewhere. So if there's no fatigue and no cervical lymphadenopathy, it is not likely that it is infectious mononucleosis. Let me repeat. The patient is not having fatigue, and on physical examination, no lymphadenopathy in the axillary region, head and neck region, then it is not likely that it is infectious mononucleosis. Now, back to what we are likely going to do to arrive at definitive diagnosis. The history is the first thing. Then the history, who are we dealing with? A young or adolescent patient or young adult? We want to know. Establish that then. Brief history about signs and symptoms like fever, sore throat, malaise, fatigue, and then we'll run into the physical examination, checking the lymph nodes, right? The axilla, the head and neck region. And then we have the tonsil, the pharynx inspected. Then the palate for petechiae. And of course, if we are suspecting infectious mononucleosis, it will be appropriate that we do less of abdominal palpation. We should not have deep palpation here. Because if there's splenomegaly on light palpation, we should just end it there and call for ultrasound. Okay? After that, the physical examination, we've talked about the abdomen, the lymph nodes, the oral region, then the neuro examination, because there might be complications already that would have set in. Of course, cardiovascular system, the respiratory system, and the renal system will also be examined because there's likelihood of complications already. Then we will head to the lab. What are we looking for? We are looking for Epstein-Barr virus-specific antibodies, then the possibility of reactive heterophile antibodies. For definitive diagnosis, we don't need to waste our time on reactive heterophile antibodies. If it is positive, yes, it might be pointed to that with the presence of the atypical large number of abnormal lymphocytes. That is fine, but once we have Epstein-Barr virus-specific antibodies, for this, we are done. That's okay. But if we don't have that, then we can do reactive heterophile antibodies, have white blood cells with differential, know the value of platelets because we might be dealing with thrombocytopenia, then we'll be able to watch against possible bleeding. Then, of course, all these antibodies issue is inside a monospot, okay? We can swab the throat to find out if we're dealing with group A streptococcus because of the sore throat, right? Then we can have ELISA, enzyme-linked immunosorbent assay or polymerase chain reaction test. Because of possible complications, let's check the liver for liver function test and the renal system that may be down with renal failure or glomerulonephritis, with renal function test. Then, since we have emphatically repeated in the course of this presentation in the last 27 minutes that splenomegaly is a big issue and we don't joke with it. So, I will call for ultrasound, abdominal ultrasound. Let's know the size of the spleen and the size of the liver. And of course, we can ask for abdominopelvic X-ray or chest X-ray, as the case might be. So, depending on how the patient presents, whether or not complications would have set in, that would determine how far the investigations will go. But in summary, Epstein-Barr virus specific antibodies and white blood cell counts and differentials is just too necessary to be done, must be done. Now, the differential diagnosis. In other words, if it is not infectious mononucleosis or kissing disease, what else could it be that will be presenting in this manner? It might be group A streptococcus, might be cytomegalovirus, can be tuberculosis. Tuberculosis will present with generalized lymphadenopathy, might be lymphoma, might be hepatitis, particularly when there is right upper chondral pain with jaundice and itching. And it might be rubella with rashes, systemic lupus erythematosus, might be leukemia, might be autoimmune hemolytic anemia, might be HIV. Remember, Epstein-Barr virus negative infectious mononucleosis might be as a result of certain drugs. It can even be some antibiotics. Might be as a result of bleeding dyscrasia, particularly when we play nosebleed. Might be as a result of toxoplasmosis or liver cirrhosis. The fatigue might be as a result of chronic fatigue syndrome. The treatment of mono is not such a big deal. It is mainly supportive. Remember, this is a self-limiting condition. It is a viral condition, so we don't need antibiotics. No antibiotics here. Except if there is secondary bacterial infection, like in the case of pneumonia, and you've done the sputum test and it's giving you specific organism on the microscopic control and sensitivity, then there's no need to waste time on that. You just go ahead. But it is self-limiting, so the treatment is mainly supportive, and it's going to include, please rest. Rest for some days. Take generous fluid. Eat good food. Decrease fun that will involve physical contact with people, particularly because we are afraid of splenic enlargement that may lead to splenic rupture. Few medications will be used, but let me go back. No contact sports. No, until you are cleared. Okay. Few medications will be used here. You can grab the Tylenol or non-steroidal anti-inflammatory drugs, particularly to deal with the fever and the pain. With or without corticosteroid. Corticosteroid will become helpful when there is airway obstruction, fulminant liver failure, severe hemolytic anemia, and aplastic anemia. We may make use of acyclovir depending on the presentation and the severity. Some will use steroids in emergency situations or just in emergency room, even with ordinary symptoms. So follow the protocol in your centers, please. In the case of spots, see part of the treatment because I just want to emphasize and re-emphasize the danger that the splenic enlargement could pose. Do you know why I feel concerned? Nobody should die because of infectious mononucleosis. So, there is no spot if the spleen is enlarged. And there will be no spot if you are still fatigued. And it's not likely that you'll be cleared to go back to hockey if you are still within the first 30 days of the infection onset. Yes, you may be able to go back to your sport if none of what I've listed above is occurring in you. And that is going to be after 1 month that you've been diagnosed with mono. And lastly, on spleen and mono, I'll start my warning from there that splenic rupture is a possibility. So let's get the symptoms and signs. Symptoms first. The individual will complain about a sudden onset of abdominal pain in left upper quadrant. The pain is going to be sharp and it may be associated with dizziness or heart racing. On examination, we are likely going to pick severe tenderness with gagging. The blood pressure may drop. The heart rate may rise depending on where we are as per the hypovolemic shock. Then the level of consciousness, depending on where we are, right? And of course, the individual may die if there is no immediate surgical intervention to stop the bleeding from the ruptured spleen. So when there is severe abdominal pain, it could be from mesenteric adenitis or ruptured spleen, and sometimes could even be from the liver, because there's likelihood of acalculous cholecystitis. So just call 911 when you pick any of the signs or symptoms of splenic rupture, 911 right away. When you have severe abdominal pain, 911 right away. When you are dealing with difficulty breathing or difficulty swallowing, remember enlarged tonsils can block both the trachea and esophagus. And when you are battling with severe fatigue that you can't even get up to eat food, to do anything, that may become disastrous. So under these scenarios, call 911, please. I said earlier that infectious mononucleosis is not expected to kill anyone, but some will have very severe immune compromised status and it may kill them. And some, because they won't wait for the spleen to regress, then they have contact spots and have splenic rupture. If there's no appropriate intervention on time, then they kick the bucket. But now let's go through other possible complications from mono. Some may develop seizures, others will have Bell palsy, some will have encephalomyelitis, and others will have Guillain-Barré syndrome. Some will have problems with renal system, having glomerulonephritis, or even renal failure. The liver is not spared with possible acalculous cholecystitis, while the pancreas or some will suffer having pancreatitis. Even the male genital area is not spared because some can come down with inflamed testicle, while the respiratory system could suffer pneumonia, pleural effusion, and possible respiratory obstruction. The gastric system can develop cancer, while CLL cancer can become bad, giving us Richard syndrome. There may be exacerbation of autoimmune hemolytic anemia, while some will actually have secondary bacterial infection, and then others will develop genital ulcers, and the heart could suffer as myocarditis. And lastly, some people can come down with bucket lymphoma. So complications following mono is enormous. Each of these is bigger than mono itself. Now, the prognosis. Like I've said earlier, this is a self-limiting condition with the possibility of full recovery in majority of affected individuals. Then, after recovery, long-term immunity will mostly follow. Acute symptoms will be expected to resolve in 2 weeks, with or without treatment. Some symptoms like fatigue and ability to function may not return to normal for about 6 to 18 months. So, as an employer, if a staff or a member of staff comes down with infectious mononucleosis, just understand with them that they may not be pretending. For 1.5 years, they may not be able to function properly. Fatigue is more pronounced in females. So the statement I've just dropped, just add this to it, particularly in female member of staff. Fatigue will be worsened in individuals with associated depression, and death may occur in individuals with decreased immune system. Before saying bye for the moment, let me remind you again that when there is splenic enlargement, understand with your physician, no contact spot until you have been cleared, and it's likely you're going to be cleared with the aid of ultrasonography. Thanks for listening. Please remember to share this and remember to subscribe to my channel. I appreciate it.